Module 9, Dermatology, Infestations, Ophthalmic, and Otic Preparations Overview. This module reviews the clinical use of drugs and agents used to treat common skin, eye, and ear conditions. This module focuses primarily on topical drugs divided into 4 units: A, dermatologic; B, ophthalmic drugs; C, otic drugs; D, infestations. Unit A, dermatologic, lecture notes, dermatologic skin conditions. Dermatologic issues in primary care are broadly classified into infectious, which include bacterial, viral, fungal, and non-infectious, such as allergic reactions, malignant lesions, and lesions related to trauma or injury. Fungal infections may also be non-infectious. Drug classes include antibacterial, antivirals, antiseptics, antifungals, and topical steroids for decreasing inflammation and pruritus. Herpes 1 and 2 are viral infections which manifest in painful skin lesions. The treatment of HSV will be addressed in Module 6. Bacterial skin infections are common. The most common pathogens that cause skin infections are Staphylococcus aureus and Streptococcus pyogenes. Both are gram-positive. It is uncommon to see gram-negative skin infections in healthy, immunocompetent individuals. As with most conditions, the savvy provider will start the plan of care by considering the severity of the condition and an understanding of the most likely pathogen. Bacterial infections may be treated with topical or systemic agents. Topical agents effectively treat a localized mild infection. Patients will frequently develop sensitivity to neomycin. Local allergic reactions to neomycin are easily confused with worsening infection and confound treatment. Therefore, other agents may be a better option in the treatment of local mild skin infections. Mild to moderate impetigo, which typically presents as honey-crusted lesions, is usually treated topically with mupirocin, which is bacitracin or Bactroban, if lesions are few. Severe impetigo that seems to be spreading or is on several different locations on the body may need a combination of oral and topical application. Once again, note that the plan of care is based on severity of condition. Methicillin-resistant Staphylococcus aureus MRSA is a common cause for skin abscesses, which is an accumulation of pus in the dermis or subcutaneous tissues. Healthcare providers should consider MRSA as a differential when evaluating infections of the skin and soft tissues, especially in the presence of an abscess. The CDC outpatient management of skin and soft tissue infections in the era of community-associated MRSA guidelines recommend incision and drainage, C&S, education on wound care and hygiene, and follow-up in the absence of systemic symptoms, severe local symptoms, and immunosuppression. Become familiar with the CDC algorithm. If you visit the CDC MRSA page, you can download the free pocket card with the MRSA management algorithm. Be sure to review treatment of MRSA for nasal carriers. Steroids and topical steroids are useful for non-infectious inflammatory conditions. Topical steroids are used for a wide variety of skin conditions. Despite their frequent use, these drugs are not without side effects. For example, a topical steroid will worsen a topical dermatologic infection. You need to be certain that you are treating a histaminic reaction versus an infection. Generally speaking, topical corticosteroids are contraindicated as monotherapy in primary bacterial infections, treatment of rosacea or acne vulgaris. After differentiating infection versus histaminic reaction, the next step is to determine severity to guide treatment choice. General rules for use of steroids: carefully choose potency from low to high. When prescribing any medication, remember the general start low, go slow principle. Super high potency products are used infrequently. Most often, you will prescribe intermediate to high potency topical steroids. Steroids should be used only for brief periods of time, no more than 2 weeks for adults and 1 week for children. Fluorinated agents are stronger than non-fluorinated agents. Choose the delivery vehicle based on the goal of therapy. Ointments are more occlusive and therefore more potent. Creams are less occlusive and usually less potent. Lotions are usually the least potent. Gels, aerosols, lotions, and solutions are useful in heat-bearing areas. Some mechanisms will increase exposure, sometimes more than intended. Occlusive dressings will increase penetration of the drug. Diapers are included in this category. Depending on the situation, this increased delivery of the steroid may either increase efficacy or result in a dose that is too high. Avoid permeable areas such as face, groin, or axilla. If needed, a general rule is to use mild potency steroids unless otherwise indicated. Caution patients to apply sparingly. Local use of these drugs can lead to skin thinning if used too long, at a too high potency, or under an occlusive dressing. They can also cause dry and telangiectasia. While topical steroids are safer than systemic, topical application may cause systemic changes. Systemic absorption can cause HPA axis suppression, Cushing's syndrome, hyperglycemia, and glycosuria. Avoid prolonged use or change to less potent corticosteroids when possible to minimize risk. Acne and rosacea. Acne is a common skin condition that can be disfiguring and a cause for embarrassment, particularly in adolescence. Typically, acne begins at puberty and is related primarily to testosterone production and affects 85 to 90% of all teenagers. While not known to be causative factors in the development of acne, certain foods, dirt, and stress may exacerbate acne that already exists. Certain medications may also induce acne outbreaks, such as anti-seizure, anti-tuberculosis drugs, antidepressants, or steroids. Acne is classified as non-inflammatory when there are closed and open comedones. Inflammatory acne includes erythematous papules, pustules, nodules, and cysts. Treatment options for acne include both topical and oral systemic treatments. Topical treatment is preferred to systemic if the topical approach reduces or resolves the acne. Topical treatments are divided into two categories, retinoids and antibiotics. Oral or systemic treatments are classified into three categories: oral antibiotics, hormonal therapy, and isotretinoin or oral retinoid. The first step in treating acne is to determine severity and classification. The next step is to begin a stepwise treatment plan. Note, treatment plan is based on severity. Be familiar with this algorithm. For mild acne, use benzoyl peroxide, which is over the counter. If no improvement in 4 to 6 weeks, add a topical, combined topical antibiotic or retinoid. If no improvement, treat as moderate acne. So for moderate acne, you start out with a topical, a combined topical antibiotic product, or topical retinoid plus the topical antibiotic. If no improvement in 6 to 8 weeks, add an oral antibiotic, such as tetracycline. If no response in 6 to 8 weeks, change antibiotic to minocycline. If no improvement in 4 to 6 weeks, no response, refer to dermatologist. So after you've added an oral antibiotic, such as tetracycline, if you have a positive response, you can also use benzoyl peroxide, which is over the counter, and then go to maintenance dose of oral or topical antibiotics. For severe nodular or recalcitrant acne, refer to a dermatologist. The first-line non-pharmacologic approach is washing the face gently 2 to 3 times daily with a mild soap, such as Basis, Cetaphil, Neutrogena, or Purpose. Avoiding oil-based facial products and cosmetics. Using earbuds when talking on cell phones and changing the pillowcase regularly are all daily practices that may help prevent exposure to excess oils and the development of acne. The first-line treatment for inflammatory acne. For acne that does not improve with the above recommendations and becomes inflammatory acne, a combination approach is recommended for an optimal synergistic effect. Topical treatment is first line and may include a comedolytic agent such as retinoic acid, a comedolytic bactericidal agent such as benzoyl peroxide, or a topical antibiotic, which would be clindamycin 2% or erythromycin 2 to 3%. Retinoic acid, which is retin-A or Avita, is a vitamin A derivative that causes drying of the skin and must be used sparingly. Topical antibiotics should not be used as monotherapy, but should be combined with benzoyl peroxide to prevent the development of antimicrobial resistance. Benzoyl peroxide, 2.5 to 5%, can be used as single drug therapy, but its activity is enhanced when combined with other agents. It is important to attempt these first-line approaches before progressing to systemic medications. Sufficient time must be given for the first-line topical medications to take effect, which may be from 6 to 12 weeks. Second-line treatment for moderate to severe acne or mild acne that does not respond to first-line approach, initiate oral antibiotics. Tetracyclines, clindamycin, and erythromycin are most commonly used. Erythromycin is indicated if tetracycline is ineffective or if pregnancy is a possibility. Tetracycline during pregnancy is contraindicated as it may cause discoloration of infant teeth. Retin-A is also used for moderate acne. Most often, this stage of acne will require long-term therapy, and clients should be advised that it usually takes at least 6 weeks for skin to turn over. Allow at least this length of time before expecting significant improvement. Second-line treatment may also include combined oral contraceptives, COCs, which serve the dual purpose option for acne treatment and women of childbearing age who desire contraception. While Yaz, Estrostep, and orthotricycline all have an FDA-approved indication for acne treatment, all combined oral contraceptive formulations will help improve both inflammatory and non-inflammatory acne. The mode of action is twofold. The estrogen and progesterone in the combined oral contraceptives diminish ovarian production of testosterone and increase sex hormone binding globulin, SHBG, in the liver, which binds up testosterone. This is important because androgen or testosterone stimulates the production of sebum. Therefore, reduction of testosterone is directly correlated with a reduction in sebum and decrease in acne. The usual precautions for prescribing combined oral contraceptives must be observed. ACHES precautions and other side effects. Women should be informed it generally takes up to 4 to 6 months to see improvement. Consider extended and continuous use for maximum efficacy and pregnancy prevention. If woman discontinues her COCs, the sex hormone binding globulin may remain in the system for several months, making it seem as though acne has been cured. Third-line treatment, severe and unresponsive acne or severe nodulocystic acne, acne vulgaris, should be referred to a dermatologist whenever possible. Cystic acne is treated with another vitamin A derivative, which is Accutane or isotretinoin. Accutane has been associated with a number of severe side effects and teratogenic effects. Prior to the prescribing, dispensing, and use of this drug, the provider, pharmacist, wholesaler, and patient must enroll in an FDA computer-based risk management program called iPledge, replacement for the SMART program. As many women of childbearing age will desire acne treatment, understand indications and contraindications of treatment when pregnancy is a possibility. Be sure to review treatment of acne and preconception, pregnancy, and lactation below. Now for practice using clinical resources. Acne rosacea is a different condition than acne. Rosacea occurs in young through older adults and causes a flushed appearance of the cheeks, forehead, and across the bridge of the nose. Rosacea may include papules but not pustules and worsens with eating spicy foods, cold air, alcohol, and stress. Acne rosacea is initially treated with topical metronidazole, which is Flagyl or Metrogel. If that fails, other topical antibiotics or oral antibiotics may be used, including oral metronidazole. To avoid a disulfiram-like reaction, alcohol intake is contraindicated within 72 hours of metronidazole ingestion. Be sure to understand a disulfiram-like reaction. You should associate the use of metronidazole with this very important safety teaching about alcohol use. Even with oral treatment, rosacea may not clear. Preconception, pregnancy, and lactation acne. Preconception, while many acne medications are safe during pregnancy, some are not, and include some of the most potent teratogens, the retinoids. Allow at least 1 month or a complete menstrual cycle between complete discontinuation of any medications contraindicated in pregnancy and conception. This is called a washout period. Acne may improve, worsen, or present for the first time during pregnancy. The exact etiology is not well understood, although hormonal changes during pregnancy and the increase in sebaceous gland activity are likely contributing factors. Alterations in the immune system during pregnancy may also have an effect on the development or worsening of acne during pregnancy. Data on the safety and efficacy of acne medications during pregnancy and lactation is limited, and many sources are in conflict. In fact, pregnancy safety categories have not been designated for some due to lack of information. Make certain the patient is fully informed and that decision-making is based on all these facts. This is often the approach with medication use during pregnancy and lactation. The treatment goal is to reduce symptoms, as complete clearance of acne may not occur with medications. Informing the patient of this fact may prevent frustration and disappointment. As above, a stepwise approach is indicated. However, there are specific guidelines and contraindications for pregnant and lactating women. For example, all retinoid products, both topical and systemic, are strictly contraindicated both for women during pregnancy and for those who are planning pregnancy or those who are without adequate or effective contraception. Systemic salicylates are also contraindicated, although limited use of topical salicylates may be used for a short period of time. Topical, start low, go slow by beginning with a topical regimen. Topical medications for treatment of mild to moderate acne in pregnancy have the highest safety profile for acne treatment during pregnancy and lactation. Systemic oral exposure increases fetal exposure. In most cases, a topical antibiotic is considered safe in pregnancy and lactation. The topical antimicrobial treatments considered safe in pregnancy include the following: erythromycin, clindamycin, and azelaic acid, sulfacetamide, metronidazole, and benzoyl peroxide. Remember that while these topical applications are generally considered safe in pregnancy, there is minimal data on their safety and known effects on the fetus. Benzoyl peroxide, while there are no studies to support or contraindicate its use, this topical agent is generally recognized as safe for use during pregnancy and lactation. The systemic absorption is low and likely presents a low risk to both the fetus and the nursing infant when applied to limited areas of the maternal body. Use during pregnancy may be acceptable with proper education on risks and benefits. Benzoyl peroxide comes in various strengths from 2.5 to 20%. Consider starting with the lowest strength and confirm that the patient is not using any additional products that contain benzoyl peroxide, which would increase exposure. Dual treatment, dual use of benzoyl peroxide and topical or systemic antibiotics is an important mainstay of treatment as this combination reduces bacterial resistance. Monotherapy is not advised. A topical combination of benzoyl peroxide and erythromycin ointment is a commonly prescribed first-line regimen for safety and effectiveness. Salicylic acid, such as Sal-Ac dermal zone, is an NSAID. You will find topical salicylic acid in many OTC products. No evidence exists regarding the safety of topical salicylates in pregnancy or lactation. It is only certain that systemic salicylates are contraindicated in pregnancy. Azelaic acid has antimicrobial and anticomedonal mechanisms of action. Other than tetracyclines, most topical antibiotics are safe in pregnancy. Topical erythromycin formulas, category B, are considered safe during both pregnancy and lactation and are considered first-line topical antibiotic use. While clindamycin formulations, pregnancy category B, are considered safe during pregnancy, they are possibly unsafe during lactation. In addition, topical use of clindamycin is associated with the rare but severe side effect pseudomembranous colitis, which is caused by C. diff. For these reasons, it is best to avoid clindamycin. Tretinoins, retin-A, isotretinoin, tazarotene, adapalene, have various pregnancy categories, but are all contraindicated due to risk of teratogenesis. While topical application probably results in minimal fetal exposure, teratogenic effects cannot be excluded. Information on retin-A during lactation is limited. Avoid use in the breastfeeding mother. Oral antibiotics, if topical treatment is insufficient, systemic therapy is the next step. If possible, avoid systemic treatments in the first trimester. Antibiotics considered safe in pregnancy include, in order of preference, the penicillin, cephalosporins, erythromycin, and other macrolides, such as azithromycin. Tetracyclines, doxycycline, minocycline are category D and are contraindicated during pregnancy. Tetracyclines can reach the fetus and cause tooth discoloration and enamel dysplasia. It can also enter the fetal skeleton and cause bone deformation and growth restriction. Avoid the sulfonamide trimethoprim during pregnancy and lactation as it interferes with folate metabolism. Again, use of oral clindamycin is associated with the rare but severe side effect pseudomembranous colitis. Therefore, it is best to start with erythromycin or azithromycin. Avoid tetracycline during pregnancy and lactation. Infant exposure can be significant when using for longer than 3 weeks and can lead to infant tooth discoloration. Oral isotretinoin, Accutane, isotone are mentioned above, cause severe fetal malformations and is category X. No information is available on the effects of isotretinoin and breastfeeding. Recommend and prescribe those medications least likely to reach the breast milk, such as topical medications. PUPS, pruritic, urticaric papules and plaques of pregnancy. PUPS is common in pregnancy, mostly for prima gravidas in the 3rd trimester. If you help a woman with PUPS, she is likely to always remember you. The 2 main medications used for PUPS are topical corticosteroids and antihistamines. However, antihistamines often do not provide sufficient relief. Remember to start low with steroids, especially during pregnancy. In worst cases, a high-potency steroid such as oral prednisone, which is pregnancy category C, may be the only means for relief. Note, this is often the case with intense pruritus and poison ivy as well. Unless the woman has a mild presentation, most cases of PUPS do not respond to topical steroids. Prescribe oral steroids for a short period of time only and taper for discontinuation after 2 to 3 weeks. Risks and adverse outcomes associated with oral corticosteroids in pregnancy are rare, but include maternal hyperglycemia and infections, fetal growth restriction and malformation, and neonatal sepsis. If you are considering use of a high-potency steroid in the first trimester, obtain physician consultation. Additional therapies for PUPS include emollients, calamine, or Aveeno baths. Soaking in bath water with baking soda is an inexpensive method to relieve itching in comparison to the cost of Aveeno baths. Transfer of topical steroids into human milk is thought to be minimal. Oral prednisone is considered compatible with breastfeeding. Pruritus. Treatment of pruritus varies with the cause. Pruritus due to a local histamine reaction or contact dermatitis may be treated with a topical and/or oral antihistamine or steroid, depending on the severity. Urticaria is also treated with an oral antihistamine or steroid, depending on the severity. Idiopathic urticaria is often treated with a once-daily antihistamine such as cetirizine or Zyrtec. Chronic urticaria that is not suppressed with once-daily antihistamine may require a dermatology referral. If angioedema occurs, emergency management is required. Fungal infections. The most common fungi in primary care are Candida and Tinea. Most often, these conditions are effectively managed with topical treatment. Occasional systemic therapy is necessary in the case of difficult-to-treat infections. Systemic antifungal therapies such as fluconazole or diflucan are typically azole-type drugs. Drugs ending in azole are notorious for interacting with warfarin, theophylline, the macrolides, the statins, and other drugs metabolized through the CYP450 metabolic pathway. Therefore, the routine use of systemic antifungals should be avoided. Be sure to consider drug interactions and safety when prescribing antifungals. One exception to the use of systemic antifungals is the treatment of thrush. This is a common candidal infection found in nursing mothers and babies. Oral mycostatin, which is a nystatin suspension, is the drug of choice, as it is safe for the infant and the nursing mother. Tinea may occur in multiple locations in the body. Tinea is described as swallows on the feet, pedis, tinea pedis, athlete's foot on the body, tinea corporis, ringworm on the male genitalia, tinea cruris or jock itch on the scalp, tinea capitis on the hand, tinea manus, and under the nails, tinea unguium, also called onychomycosis. With the exception of the nails, it is treated with topical agents such as terbinafine, Lamisil, or clotrimazole, which is Lotrimin. Tinea unguium is hard to treat. The medication cannot effectively penetrate the affected area. Topicals are generally not effective. Oral agents require monitoring of liver function. Long-term treatment, 6 months for toenails, 3 months for fingernails, and present a risk of drug-to-drug interactions. Tinea of the toenails recurs in more than 80% of all cases. Even with oral therapy, complete resolution is uncommon. Tinea capitis, which is ringworm of the scalp, also usually requires systemic or oral antifungal agents. Griseofulvin is the drug of choice. It must be used for several weeks and liver function must be monitored. Tinea versicolor is a skin condition caused by a superficial yeast infection caused by an overgrowth of Pityrosporum ovale and occurs in subtropical and tropical areas. Moist skin conditions are more prone to this infection. First-line treatment is with selenium sulfide solution as a lotion or shampoo applied once daily for 3 to 4 weeks. Oral itraconazole may be utilized as second-line in refractory cases. FYI, the Sanford Guide addresses use of antifungal agents and makes recommendations for choice based on involved body area and suspected fungi causing the symptoms. The CDC STD guidelines is gold standard resource for vulvovaginal candidiasis, VVC. Burns, first and small second-degree burns may be treated in a primary care clinic. Silver sulfadiazine, Silvadene, Thermazine, and SSD cream is most commonly used as it is cooling, has antimicrobial properties, and is usually painless. Any antibacterial ointment can be used, such as polymyx B, bacitracin, or neosporin, which is neomycin, polymyxin, and pramoxin HCl together. Often a low-dose topical steroid may be added to decrease inflammation. Burns should be covered with non-adherent dressing to decrease pain and risk for infection. Second-degree burns covering large parts of the body or third-degree burns need referred for care. Sunburns are treated like any other first or second-degree burn. As with any plan of care, it is imperative to assess for allergies and understand components of medication. Silver sulfadiazine, silvadene, thermazine, and SSD cream are contraindicated in patients with sulfa allergies. Until the agent that induces the reaction is identified and removed, the reaction may continue. The longer severe dermatitis is present, the longer it takes to resolve. The management begins with identification of the agent and its removal. Next, topical corticosteroids are prescribed. If necessary, oral corticosteroids may be needed. If you are treating a rash like poison ivy or oak, systemic corticosteroids may be administered for 2 weeks. Because shorter courses are notorious for allowing poison ivy dermatitis to relapse. Psoriasis is a chronic inflammatory skin condition. The management is in a stepwise approach. Mild to moderate psoriasis begins with topical medications and phototherapy. Severe psoriasis involves topical medication, phototherapy, and systemic drugs. Consider co-management or referral for treatment of severe psoriasis. Topical corticosteroids are used for anti-inflammatory effects on the plaques. Moderate to high potency steroids are often used because the thick plaques are often steroid resistant. But remember the special considerations of steroid use. Consider the age, area, and region of application. In other words, if the plaques are in the intertriginous areas, face or genitals, select low potency to reduce adverse effects. Remember that occlusion increases absorption and potency. This is a case where using a steroid preparation with an occlusive dressing works to improve results. Because psoriasis is a chronic inflammatory condition, intermittent pulse therapy helps to reduce long-term adverse effects. Remember, creams are good for oozing and intertriginous areas. Ointments and occlusion help with dry, scaly, and thick lesions. Calcipotriene, which is a vitamin D3 derivative, coal tar, and tazarotene are topical medications also used in the treatment of psoriasis. Be sure to review mode of action and precautions for each. Calcipotriene should not be used in patients with hypercalcemia of vitamin D toxicity. Tazarotene is pregnancy category X. Review the text for additional precautions for prescribing. Unit B, ophthalmic drugs. The most common ophthalmic problems in primary care include conjunctivitis, which may be bacterial or allergic, blepharitis, dry eyes, and glaucoma. Blepharitis is an infection or irritation of the eyelid margin. Causes are bacteria, hypersecretion of the sebaceous glands, meibomian gland dysfunction, or a combination. Staph and seborrheic blepharitis involve the anterior eyelid. Goals of drug therapy are to reduce the symptoms of the condition and eradicate the causative microbe. Blepharitis is chronic, so the condition will wax and wane. Patient education involves improved eyelid hygiene, washing with baby shampoo, warm massages, and occasional antibiotic use. Patients should avoid wearing contact lenses during flare-ups. Treatment: first-line topical antibiotics such as bacitracin ointment or erythromycin 0.5% ophthalmic ointment are first line. If improvement is not noted after several weeks or if the condition worsens, refer to an ophthalmologist. Bacterial conjunctivitis or pink eye is treated with antibacterial ophthalmic drops or ointment. Typically, ointment is used in infants and young children as drops are difficult to instill. Adults usually prefer drops. Application to both eyes is indicated, even if only one eye is affected initially. Bacterial conjunctivitis is highly contagious. Treatment of acute bacterial conjunctivitis with an anti-infective agent lessens both the contagion and the duration of the disease. It alleviates patient discomfort and facilitates earlier resumption of normal activities. Good hand washing is essential before and after installation of eye medication. Neonatal chlamydial conjunctivitis. Neonatal eye prophylaxis after birth has been a routine practice in the U.S. for over a century. It started in the late 1800s with the application of silver nitrate to prevent neonatal ophthalmia neonatorium, which is ON, and the subsequent blindness due to gonorrhea. While this practice resulted in a dramatic decrease of neonatal ophthalmia neonatorium and related sequelae, it is questionable if this is necessary or even some practice today. Newborns are exposed to gonorrhea or chlamydia during birth if the patient has an untreated infection with either organism. Gonococcal ophthalmia can cause blindness or serious damage to the eyes. While chlamydial conjunctivitis does not cause serious ocular damage, infants with chlamydial conjunctivitis need to be observed for the more serious chlamydial pneumonia. In most states, administration of newborn ocular prophylaxis as soon as possible after birth is a legal requirement. The regimen is a single application of erythromycin 0.5% ophthalmic ointment in each eye. Some states lack opt-out policies, yet many countries no longer require universal prophylaxis or offer parental choice to opt out. Routine prophylaxis is a growing debate in this country. Issues of overuse of antibiotics, antimicrobial resistance, ineffectiveness of the topical treatment, and effectiveness of preventive measures, screening and treatment of GC, gonorrhea, chlamydia prenatally contribute to the evidence that suggests that routine prophylaxis is unnecessary. Allergic conjunctivitis can be treated with mast cell stabilizers, such as cromolyn sodium, iodoxamide, topical antihistamines, a combination antihistamine and mast cell stabilizer, or oral antihistamines. If used regularly, decongestant drops may cause rebound congestion. Due to potentially severe side effects and the possibility that an infection may be masked with the use of glucocorticoids, use of these products is recommended for use only by ophthalmologists. Mast cell stabilizers may take several weeks to see a benefit, so this is not usually first-line treatment. If severe, topical corticosteroids can be used. Dry eyes are treated with artificial tear substitutes and ocular lubricants. These are to be used daily, and there are no adverse effects associated with daily and continuous use of preservative-free solutions. Glaucoma. There are two types of glaucoma: primary open-angle glaucoma and acute angle closure glaucoma. This irreversible disease can be prevented through early detection and maintenance of intraocular pressure at normal levels. If either outflow of aqueous humor is impeded or there is an overproduction of aqueous humor, intraocular pressure increases and causes optic nerve damage. While a specialist will evaluate and initiate medications for these conditions, the advanced practice nurse will monitor medication use and side effects, note any drug-to-drug interactions, and provide educational needs. Thus, familiarity with these medications is necessary. Primary open-angle glaucoma, POAG, is the most common form of glaucoma. Risk factors are elevation of intraocular pressure, 2. Black race, 3. Family history of primary open-angle glaucoma, and 4. Advancing age. Treatment of POAG is directed at reducing elevated intraocular pressure, which can slow or halt disease progression. Treatment for primary open-angle glaucoma is daily medication which either decreases ocular pressure by decreasing aqueous humor production or improving outflow. Major first-line drugs used for this purpose include beta blockers, prostaglandin analogs, and alpha-adrenergic agonists. Prostaglandin analogs increase aqueous outflow, while beta blockers and alpha-adrenergic agonists decrease aqueous formation. Prostaglandin ophthalmic solutions are often the initial treatment of choice for open-angle glaucoma due to fewer side effects when compared to beta blockers. Topical beta blockers are contraindicated for use in patients with bradycardia or AV block. Be sure to review cautions regarding use of beta blockers in your text. Do not prescribe oral beta blockers with ophthalmic beta blockers as they have an additive effect. Ophthalmic beta blockers are pregnancy category C. Yet remember to review the data and the most recent PLLR. Angle closure glaucoma is an emergent situation caused by displacement of the iris over the trabecular meshwork, which prevents drainage of aqueous humor from the anterior chamber. This condition is extremely painful with sudden onset and can cause irreversible loss of vision if not treated promptly. Initially, drops are utilized to control acute attack until corrective surgery is performed. Acute eye pain with sudden onset is always an emergent condition, and quick assessment, consultation, and referral are essential. Module 9, Unit C, otic drugs. Otitis externa is an infection of the outer ear and ear canal and is associated with swimming, trauma such as Q-tips, hearing aids, and high and humid environments. Mild or resolving otitis externa can be treated topically with an acidifying agent to present acetic acid or vinegar, a drying agent alcohol, and or anti-inflammatory hydrocortisone. A solution for use before and after swimming to prevent otitis externa may be made at home by combining 1/3 white vinegar and 2/3 rubbing alcohol. By the time the patient arrives at your clinic, they usually have a moderate to severe otitis externa and topical antibiotics are required. If significant canal edema develops, an earwick may be used to facilitate delivery of topical medications into the medial canal. Fluoroquinolone eardrops with or without a steroid are the mainstay of treatment in 90% of cases, as 90% of cases are bacterial in origin. Oral antibiotics are rarely needed. Administer oral antibiotics to individuals with cellulitis of the face or neck, skin, or where severe edema of the ear canal limits penetration by topical agents. Topical agents can achieve very high local concentrations in comparison to oral antibiotics. In the past, a 3-drug combination was used, hydrocortisone, neomycin, and polymyxin B. However, there is increasing bacterial resistance, there is a slight risk of ototoxicity, and neomycin sensitivity causes local swelling and erythema, and these drops cannot be given with tympanic membrane perforations or with tubes in the ears. Selected fluoroquinolone drops may be used with perforation of the tympanic membrane and or pressure equalization tubes. These are ciprofloxacin and dexamethasone, Ciprodex, otic, and ofloxacin, fluxin. Oral fluoroquinolones are contraindicated in children less than 18 years old due to risk of tendon rupture. Dicloxacillin or TMP SMX are recommended in children if oral antibiotics are given. Also, note the FDA warning for fluoroquinolone use of all ages. Less commonly, otitis externa may be due to a fungal infection. In such cases, if topical treatment is ineffective, an oral antifungal is indicated. Occasionally, for otitis externa, it is necessary to temporarily use an otic analgesic. Topical analgesics should not be used if there is a chance of tympanic membrane perforation. Antipyrine benzocaine, the generic form of Aralgan, is an example of a topical analgesic that might be used for pain associated with otitis externa. Aralgan was discontinued in the U.S. market in 2008, but the generic form benzocaine antipyrine is available. Oral acetaminophen or ibuprofen is helpful for pain relief. Ceruminosis is earwax occluding the ear canal, can lead to hearing loss and local irritations. Cerumen may be softened for removal with irrigation by using a ceruminolytic over-the-counter solution such as Cerumenex, which is triethane olamine polypeptide oleate, but should not be performed if the tympanic membrane is ruptured. Acute otitis media may be bacterial, viral, or both. This is a result of migration of a virus or bacteria through the eustachian tube to the middle ear. It is the most common upper respiratory infection, occurring in 60 to 70% of children by 1 year of age. Depending on the age and/or severity, observation may be the first-line approach. The most common bacteria associated with acute otitis media are Strep pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. Strep pneumonia is the most common. Be sure to review the textbook on how to diagnose acute otitis media. An algorithm: the child presents with confirmed diagnosis of acute otitis media for age less than 2 years with non-severe illness or uncertain diagnosis. Observe for 48 to 72 hours with assurance of appropriate follow-up. If there is improvement after the observation period, follow a patient in 3 to 4 weeks. If not, begin appropriate antimicrobial therapy. So in other scenario, age less than 2, uncertain diagnosis, or older child with severe illness. Does child have a fever equal to or greater than 39 degrees centigrade or severe otalgia? If yes, amoxicillin with clavulanate, 90 milligrams per kilo per day of amoxicillin, or appropriate alternative for penicillin allergic patient. If no fever or no severe otalgia, amoxicillin 80 to 90 milligrams per kilogram per day is first choice antibacterial. If patient responds to treatment, yes. Patient follow-up on completion of antibiotics in 3 to 4 weeks. If no, reassess and confirm diagnosis of acute otitis media, change antibacterial therapy. Treatment for acute otitis media and treatment length. Drug of choice for when decision is made to treat with antibiotics per American Academy of Pediatrics. Amoxicillin 80 to 90 milligrams per kilo per day in 2 divided doses for a child with acute otitis media who has not received amoxicillin in past 30 days, does not have concurrent purulent conjunctivitis, is not allergic to penicillin. Cephalosporins recommended for most children with penicillin allergy. Or amoxicillin clavulanate 90-6.4 milligrams per kilogram per day if amoxicillin has been received in past 30 days, if has concurrent purulent conjunctivitis, if has a history of recurrent acute otitis media unresponsive to amoxicillin. The duration of antibiotics: 10 days if severe, or if less than 2 years old, 7 days if aged 2 to 5 years with mild to moderate symptoms, 5 to 7 days if equal to or greater than 6 years old with mild to moderate symptoms. Short-acting antibiotic treatment for 5 days might be less effective than 8 to 10 day treatments for children with acute otitis media. Ceftriaxone 50 milligrams per kilogram IM once may be as effective as 10 days of oral antibiotics. Boy, that's interesting. Reevaluation: the patient should be showing improvement within 48 to 72 hours after initiation of treatment. Patient education should include informing the patient parent that if symptoms are not beginning to resolve within 72 hours, they should return to the clinic for a reevaluation. Possible causes for treatment failure are as follows: resistant organism, viral infection, inadequate concentration of antibiotic, non-adherence. Treatment of antibiotic-resistant acute otitis media. Resistant acute otitis media is increasing in the U.S. due to overuse of antibiotics. Antibiotic resistance is suspected with persistence of symptoms: fever, earache, otorrhea, and a red bulging tympanic membrane for 2 to 3 days after initiation of antibiotic treatment. The following are risk factors for the development of antibiotic-resistant acute otitis media. 1. Daycare attendance. 2. Less than 2 years old. 3. Antibiotic exposure for 1 to 3 months prior to current infection. And 4. Winter and spring seasons. Module 9, infestations. Scabies and pediculosis. There are 2 skin parasites commonly seen in the primary care setting, scabies and pediculosis or lice. Just like tinea, pediculosis may occur in several places. Pediculosis of the scalp, pediculosis capitis, or head lice is most common. Pediculosis of the pubic hair is pediculosis pubis. Occasionally, there will be body lice called pediculosis corporis. Treatment of these infestations involves killing live mites or lice and killing the larvae and egg sacs in the hair or burrows. Scabies treatment involves applying a cream all over the body, including the soles of the feet, starting at the neck. Usually permethrin 5%, also called elimite or acticin. It is applied at night after a bath and washed off in the morning. Pediculosis is treated with a rinse available over the counter called Nix. Permethrin, which is permethrin 1%. Pediculosis. Pruritus is a typical presenting symptom in persons with either condition. Determining the etiology is important and straightforward based on history and physical examination. An accurate diagnosis may have an impact on reducing resistance of lice to currently available treatments. The pruritus may take 2 to 6 weeks to develop after the first exposure. NIT resolution can take months, and requiring a no-NIT policy at school is not recommended by AAP. To confirm diagnosis, only 1 loss in the head is necessary. For successful eradication of head lice infestation, treating 7 to 10 days later according to their life cycle provides a better chance of successful treatment. Careful attention to environmental cleaning are key to treatment of any infestation. Scabies. When treating patients with scabies, you know that lesion distribution typically include finger webs, wrists, axillae, elbows, and buttocks. Distribution may also occur in the genitalia of men and breasts of women. The rash from scabies is typically face-sparing. Treatment with permethrin 5% applied from face down to soles of feet and left in place 8 to 14 hours before showering. Topical permethrin is the preferred treatment. If oral medication is needed, prescribe ivermectin. Treat family empirically to avoid further spreading. Topical corticosteroids are used after scabies treatment to relieve inflammation and itching. Pregnancy and lactation. Permethrin is category B, is considered safe in pregnancy and lactation. With small amounts of topical application, very little is absorbed. Permethrin is also rapidly metabolized, further reducing infant exposure. Lindane, a product previously known as Quell, is only used for recalcitrant cases of pediculosis. This agent was found to be neurotoxic and estrogenic. Lindane is contraindicated in pregnancy, lactation, and with routine use for children.